Good evening. My name is Lori Ann Blanton. I am a doctoral student at the University of South Alabama. I will be presenting a quality improvement project to you entitled Transitional Care Planning with an Integrated Clinical Network. I'd like to begin with some background information. According to the Centers for Medicare and Medicaid Services, patients presenting to the hospital with a primary or secondary diagnosis of heart failure, average length of stay should be approximately 3.8 days. Those same patients should remain out of the hospital for more than 30 days after discharge. The selected hospital's length of stay for heart failure patients was 5.2 days with a 20% 30-day readmission rate. The readmission rate for the hospital's region was 16%. The length of stay and 30-day readmissions result in poor patient outcomes, rising costs to care for this population, and reduced reimbursements. One study conducted in Olmsted County demonstrated the lifetime cost to care for heart failure patients after diagnosis rising to over $83,000 in the year 2006. Keeping in mind that the Centers for Medicare and Medicaid Services prospective payment considers cost and performance of hospitals and adjusts reimbursements accordingly. The goal of this project was to reduce the length of stay for heart failure patients by half a day and reduce 30-day readmissions to below 16%. The project focused on heart failure patients who were discharged back to the community, primarily on the 14th floor of the acute hospital. The software utilized for this project was Epic software, the documentation software utilized by the hospital. There was manual data collection and a telephone assessment tool. We also used SPSS software. This data would be collected and analyzed for outcome. The interventions to achieve the desired outcomes included identification of post-acute preferred providers. The hospital identified these providers through a year-long research undertaking to identify the quality providers in the post-acute setting. There was a discharge assessment tool utilized by care managers within 24 to 48 hours of admission, and the care managers collaborated with the post-acute providers to transition those patients identified as needing post-acute services. Within 24 to 48 hours following discharge, post-acute phone calls were made to patients to assess their transition back to the community and admission to post-acute provider services. The patients selected had a primary or secondary admitting diagnosis of heart failure. All the patients observed for the purpose of this project were admitted on the 14th floor of the hospital. The care managers were responsible for obtaining patient history within 24 to 48 hours of admission. The patients were offered choice of preferred providers or any provider of their choice. Patients were inclined to select providers that were affiliated with the hospital. The care managers then collaborated and coordinated transition of care to the providers before the actual discharge. Support staff assumed responsibility of calling patients after discharge to confirm the connection with the post-acute provider and an uncomplicated transition from the hospital to the community. The Epic software was the charting system utilized by the hospital. This charting system kept accurate records of admission, time lapse between admissions, and visits to some of the neighboring hospitals. The care management department has a division statistician, nurse statistician, who collects and aggregates much of the data for government reporting and hospital performance. She was able to assist in pulling manual data related to the observed patients. The discharge planning screens utilized by the care managers provided valuable data in identifying those patients at risk for readmission or in need of post-acute services. The discharge phone calls allowed follow-up on patients' status at home, including identification of potential complications and confirming admission to post-acute provider services. The SPSS software was utilized to determine the degree of significance of the proposed outcome. The interventions included the discharge assessment screens being completed 24 to 48 hours after admission by a care manager, the identification of post-acute providers based on patient choice. The care managers did provide the same level of collaboration even when non-preferred providers were elected. The collaboration with provider began before actual discharge to ensure a smooth transition. The completion of the discharge phone calls included an ability to answer questions and prevent return to the emergency department. While these steps were followed all for the heart failure patients admitted, the patients readmitted within 30 days were also quickly identified to address missed opportunities. There was much information collected. The first step was to identify the selected patient. Then the identified patient's data were collected as related to how long they were an inpatient. Did they go home with services? Did they return within 30 days? Those patients that went home received a call from the care management team. These calls originally supposed to be made by the nursing department, but due to staffing opportunities, this did not happen. The calls confirmed the patients had obtained their medicines, scheduled physician appointments, and had been seen by the post-acute provider. Then the data collected related to the length of stay and readmissions of selected populations was uploaded into the SPSS software and compared to prior year's data. The average admission rate before the project for the same period of time was 13.48%, and after the project, the average rate of readmission was 6.67. There was a total of 145 cases observed during the project, but there were no accurate numbers available for a prior year. 31 patients transitioned to the post-acute providers, and the patients reported smooth transitions from hospital to home, as evidenced by post-discharge phone calls. Of the 145 patients, 90% had a discharge assessment completed within 24 to 48 hours of admission. 55% of those patients were transitioned to the post-acute providers, and 19% of them received a post-acute discharge phone call after determining nursing had not completed. The SPS software revealed no significant difference between the two periods. There was a change in the number of 30-day readmissions in comparison to prior year. The trending pattern is similar and shows support warranting further study. Further studies will also have to consider external factors occurring. For example, the percentage of people displaced by severe weather. The training of care managers to change thinking from discharging the patient to transitioning care from the acute to the post-acute setting reinforces continuity of care. The continuity of care improved patient outcomes and reduced the risk of readmission. The length of stay did not show improvement, but due to factors outside of the project's control, it definitely warrants further study. Early identification of discharge needs can reduce the length of stay in the acute setting. The physicians also have to be included and have buy-in to early planning. In addition, there must be a process in place to address physician response times to advancing care for the acute inpatient. Their confidence in the providers that are selected has impact on the length of stay, and these physicians should have input in the selected preferred providers. Once the patient is discharged, the post-acute phone calls can circumvent fears and uncertainty that results in patients returning to the hospital. Plans must include a process and responsible party to complete post-acute phone calls. While there was not a significant degree of difference in the 2 years related to this project, there was clear clinical evidence warranting further investigation of transitional care planning with an integrated clinical network. Here are listed references used to complete this presentation. I would like to take this opportunity to thank you for listening to the presentation.